Afternoon, everybody, and thank you to the organisers for inviting me to talk today. So, like Marie, I'm going to do a very quick fly through antiphospholipid syndrome and just try and provide some information and background with regards to how we look at TMAs in pregnancy. So, what is antiphospholipid syndrome for those of you who don't manage it on a regular basis? So, it's an acquired autoimmune disorder, and it's characterised particularly by pregnancy morbidity and thrombotic complications, and this is in association with the persistence of antiphospholipid antibodies, and it can either occur primary or it can be secondary to another underlying rheumatological disorder. The first set of international criteria were defined in 1999, and they were known as the Sapporo criteria. And those were subsequently updated in 2006, and they were then known as the Sydney criteria. And what they say is that antiphospholipid syndrome is defined as the loss of 3 or more embryos before 10 weeks gestation, or an otherwise unexplained fetal death beyond the 10th week of gestation, and or the premature birth of a morphologically normal neonate before the 34th week of gestation because of eclampsia, severe preeclampsia, or placental insufficiency. Vascular thrombosis is one of the defining criteria as well, and it can basically occur in any organ. And I think this is what's particularly important to focus on today for the purposes of TMA. So these episodes can occur either arterially, venous, or can be small vessel thrombosis in any tissue or organ. So there's an extremely varied clinical spectrum of antiphospholipid syndrome, and it can vary anywhere from patients having antiphospholipid antibodies that are just picked up incidentally through to what are called non-criteria antiphospholipid manifestations, and we'll talk about that a little bit later, right through to patients who have either thrombotic or obstetric complications through to the worst presentation, which is known as catastrophic APS. So I think this diagram is probably quite a good summary of all of the places that antiphospholipid antibodies can target. And in particular here you can see that TMAs are a recognised phenomenon, and then as well as the known sort of thrombotic complications, there are also these non-criteria manifestations. So in association with thrombotic complications or a poor obstetric history, patients can also have cardiac valve abnormalities. They can have skin lesions known as livedo reticularis, which is a lacy pattern for those of you who have never seen it, neurological manifestations, and thrombocytopenia. So what do we know about the epidemiology of antiphospholipid syndrome? So some studies suggest that antiphospholipid antibodies can be present anywhere up to 5% of the general population. When we take patients who present with thrombosis, up to 14% of those patients are thought to have underlying antiphospholipid antibodies. And then when we look at women who present with recurrent pregnancy loss, up to 20% of women who have recurrent early pregnancy losses is the known cause, and 14% of women who develop preeclampsia before 34 weeks gestation are found to have antiphospholipid antibodies. The pathogenesis is poorly understood. There's no unifying mechanism as to how antiphospholipid causes all of the complications, but there have been lots and lots of studies looking at the possible underlying reasons for antiphospholipid syndrome and its complications, and it's thought to really be a multifactorial phenomenon. So there appears to be endothelial, monocyte and platelet activation, which can lead to upregulation of tissue factor production, leading to a thrombogenic state. Then, as part of the multi-hit phenomenon, you have other factors such as interaction with your coagulation regulatory proteins, complement activation, which we're going to focus a little bit more on today, and then other procoagulate conditions. So say if somebody has underlying very active lupus, or they're taking the combined oral contraceptive pill, and all of these factors then together may then lead to thrombosis. But it's very poorly understood which of these are the most important factors when it comes to the pathogenesis of antiphospholipid syndrome. With regards to the obstetric complications, most of the evidence we have actually come from animal models. And if you infuse antiphospholipid antibodies into mice, you can see problems with fetal resorption, intrauterine growth restriction, fetal death, and small litter sizes. And then some of the histology, looking at the outcomes of pregnancies in these mice models, show that there's increased complement deposition and neutrophil infiltration in the decidua. And then when these animal models who've been infused with antiphospholipid antibodies are given complement blockade or deficient or made complement deficient, then this actually prevents fetal resorption. There's very little evidence in human studies from patients with antiphospholipid syndrome with regards to the pathogenic mechanisms. And thinking about complement in particular, that's one of the areas where a lot of focus has been on with regards to the pathogenesis of antiphospholipid syndrome. So if we look at the placenta from women who have issues with recurrent miscarriage, those placentae show, or the histology shows defective placentation, reduced trophoblast invasion, and limited spiral artery transformation. Initially, the main mechanisms behind the pathogenesis of obstetric problems of antiphospholipid syndrome proposed thrombotic mechanisms as being the main cause behind this. But actually, more recently, it's thought that complement deposition and infiltration of inflammatory cells may be the more defining mechanism behind all of this. So some of the studies that have looked at women who have obstetric complications associated with antiphospholipid syndrome have shown that these women have low levels of complement. They've increased complement deposition in placentae when we look at the histology of the placenta from these women who have pregnancy losses. And also, outside of pregnancy, there have been some studies looking at markers of increased complement turnover. So some groups have previously looked at patients in very small cohorts who have had both thrombotic and obstetric complications of APS, and they've shown increased complement activation products, so increased markers C3A and C4A. But the problem is with these studies previously is that they were small and a lot of them didn't include obstetric complications of antiphospholipid antibodies. In our group in St Thomas's, we've tried to look at this also, and we use markers of factor BB and C3A disarge, which are also markers of increased complement turnover. And we looked at women outside of pregnancy. We had a group of approximately 90 women or 90 patients compared to healthy controls, and factor BB and C3A disarge were increased in all groups. And when we compared patients who had solely thrombotic complications versus obstetric complications, interestingly, there was no difference, but it did seem to point to the complement cascade as being one of the problems behind these patients with antiphospholipid syndrome. APS, it's a difficult disorder, and outside of having the specific antiphospholipid antibodies such as the lupus anticoagulant, beta-2 glycoprotein 1 and anticardiolipin antibodies, we really don't have a lot of specific biomarkers to help us predict the problems that these patients are going to run into. So it's been shown previously that of the tests that we have, that high titers of anticardiolipin antibodies are associated with complications of thrombosis and miscarriage. And the lupus anticoagulant in particular has also been associated with a high risk of both thrombosis and miscarriage. And a useful study from Pengo and his group a few years back showed that if you have positivity for more than just one antibody, so here patients may have had any subtype of antiphospholipid antibody, if you have either dual or triple positivity for all of the subgroups of antiphospholipid antibodies, that really does increase your risk of thrombosis in the setting of APS. So what other markers do we have? And one of the best predictors of risk is a patient's previous history. So if you've had a previous arterial thrombotic event, then the likely recurrent event is going to be another arterial event. And for women who have a thrombotic history compared to those women who solely have an obstetric history, those women have a risk of higher complications in pregnancy. And that was a retrospective study done by Kate Bramham and Beverly in St Thomas's not so long ago. So that's been quite helpful to help sort of try and guide us how we manage these patients in pregnancy. The problem is with the data is that all of the retrospective studies looking at the outcomes of patients in antiphospholipid syndrome are very variable. There's a lot of patients who receive varied treatment regimes, and so the outcomes with regards to preeclampsia vary anywhere between 0 and 51%, preterm delivery up to 92%, and thrombosis appears to be much lower, but then you have to think about the characteristics of the studies that are looking at the outcomes in these patients. And again, one of the studies done from our centre looked at all of the different types of women who present during pregnancy, and those with thrombotic complications do appear to have worse outcomes. So when it comes to the management of patients with antiphospholipid syndrome and TMA, so of course we have the patients who are known to have had previous thrombotic complications, and we'll manage those pregnancies accordingly. But I think suffice to say that it's very poorly recognised. TMAs can often be very poorly recognised in patients with the APS because they can present in many different guises. And Marie, of course, has spoken to you about TTP, and Lucy has spoken to you about eclampsia and preeclampsia, but certainly there have been some case reports and publications about patients who have APS and have an underlying nephropathy. That's, again, very poorly recognised, and also catastrophic APS. So just a little bit about antiphospholipid syndrome-associated nephropathies. So often, this can occur independent of lupus nephritis, and I think one of the things that's certainly very important to consider in any of you who are managing patients with antiphospholipid syndrome during pregnancy is to not sort of pass off the hypertension, hematuria, or proteinuria as possibly just related to maybe underlying preeclampsia, but to sort of think about could this represent a nephropathy. And of course, the theme of today is it can be very difficult to diagnose a lot of these disorders in pregnancy. Catastrophic antiphospholipid syndrome, thankfully, is very rare, but it is a very aggressive presentation of antiphospholipid syndrome and needs to be managed very rapidly. There are a set of diagnostic criteria, and it mainly involves patients presenting acutely with involvement of 3 or more organs, systems, or tissues. The presentation is usually less than a week. You need confirmation with histopathology of small vessel occlusion, and I think a lot of you will agree that quite often it's very difficult to get that. And then, of course, laboratory confirmation of the presence of antiphospholipid antibodies. There is a worldwide registry looking at patients with catastrophic APS. Very high percentage of those patients are female. Mean age is women of childbearing age, so it's 37 years. 46% have primary antiphospholipid syndrome and 40% have lupus, with 9% having other autoimmune disorders. There's quite often a precipitating event in catastrophic APS. So with regards to evidence that we have out there looking at TMA and antiphospholipid syndrome in pregnancy. So like I mentioned before, really there's very little data out there, but one of the studies that Jane Salmon and her group had initiated some years back was called the PROMISE study, and I think we were all very hopeful that that might give us some more evidence or biomarkers that would help us predict what types of problems these women would run into. So it was a prospective multi-centre observational study that was going to particularly look at the role of complement in lupus and antiphospholipid associated pregnancy. I believe the study completed in around about 2015, and so far one of the publications from the outcome of this study looked at patients who had complement factor mutations, so 5 out of 250 of the patients included in that study, but so far we're waiting on some more data to be published from that study. So management, as I said, can be difficult. We have a disorder where there's no predictive markers other than the antiphospholipid antibodies that we have for diagnosis. Patients who have previously asymptomatic incidental on antiphospholipid antibodies is unknown, and there's an up to 90% risk of pregnancy morbidity if these patients have had a previous pregnancy-related event. So I'm sure a lot of you know that the current management of patients who have either obstetric or thrombotic antiphospholipid syndrome is with a combination of aspirin or heparin, and of course in the interest of time I'm not going to go through all the data, but really the doses of low molecular weight heparin thromboprophylaxis that are used, they're based on the woman's previous thrombotic history. Prednisolone is really reserved for those patients who are defined as having refractory antiphospholipid syndrome, i.e. they still have pregnancy losses despite best management with aspirin or heparin, and intravenous immunoglobulin really hasn't been shown to have a role. Close monitoring of these women in association with combined hematology and obstetric input is really important in management of these cases. And then when it comes to management of patients with APS and a TMA, so if these patients have previously been recognised to have a TMA, of course, optimization of their anticoagulation is going to be really important. There have been some case reports of patients receiving eculizumab who have APS that are going for renal transplant. So maybe this is something that we need to think about in the future for those patients who do very poorly when it comes to pregnancy. Hydroxychloroquine is another potential very useful agent, as are statins. So in summary, just suffice to say that I think the theme of today is the recognition of the exact underlying disorder of these patients can be very difficult. We need probably some more new biomarkers or laboratory tests to help us define which groups are most at risk. There's an as yet undefined role of statins, hydroxychloroquine or eculizumab, and I think it's really important that if you do have a really complex patient that you phone a friend. So I'd like to thank you for your attention.